kidney transplantation. And there is also a lot of like update about the management of CMV after solid organ transplant. So I don't know, it's not moving. Sorry. So the outline of my learning objective will be to address the problem of CMV and the CMV relation to the immune system, CMV disease spectrum, diagnosis of the CMV, prevention, current lines of management of CMV infection after transplantation. We will touch about the resistance and refractory CMV emerging problem, and also I will discuss the current practice in our institute and our current protocol for the management or prevention of the CMV, propose future direction for prevention and treatment of CMV. Then we will go through case-based discussion, and we end with conclusion and take-home message. So introduction, including that the CMV virus is related to the human herpes virus type 5, which is related to the family of beta herpes virus, and it is double-stranded DNA envelope virus that with overall frequency in the range between 30 to 97%. The variation of this prevalence of CMV, it's mainly affected by the race and the age and also the geographical distribution. So we know that in developing countries, because having higher incidence of CMV infection, because it is mainly transmitted through the direct contact in our crowded cities. So Asian people and South American, they have high prevalence of CMV infection compared to US and Europe. The primary CMV infection is usually asymptomatic, self-limiting in immune-competent adults. However, CMV is an important cause of morbidity and mortality after organ transplantation, because it can cause persistent viremia, latent infection and reactivation with tissue invasion, and also can trigger allograft antigen response and cause rejection that adversely impact the outcome of solid organ transplant. However, kidney transplant recipients have a lower rate of CMV infection compared to the lung transplant or intestine or dual transplant. So let's move now to the CMV structure and the life cycle, and I will summarize this very simple. As I told you, CMV viruses belong to human herpes virus, and it is double core DNA surrounded by double layer envelope, and the main functional part of this viral structure is related to the glycoproteins, and there is abundance of glycoproteins, more than 200 glycoproteins for the CMV virus, and there is functional glycoprotein that enhance the entry of the virus to the host cell membrane through specific receptors, like in this pentamer, it is called GHGL, attached to their specific receptors and with a predilection to the invasion or enhanced entry to the epithelial and endothelial cells, while the other part of the functional glycoprotein we call trimer, GH and GL and GO, which is also attached to specific receptors that enhance entry to the fibroblast cell. So this phase of the life cycle of CMV, we call it the lytic phase or lytic pathway. Then followed by the lysogenic pathway, which is, you can see here, this is a crystallography with 3 dimensions, show the fusion of the glycoprotein in specific different sites of complex receptors, ending with the generation of a neutralizing antibody in the gray color in different sites. The idea of showing this picture because if you are identifying the binding sites of these functional glycoproteins that enhance the fusion and replication of the virus, these sites will be the future design for designing inhibitors against CMV virus infection. So after we understand the structure and the life cycle of the CMV, and after the CMV replication, we have 3 phases of CMV infection, including phase 1, which is the acute infection, and the phase 2, which is the persistent viremia, and the latent phase or reactivation phase, which is the phase 3. And this is all depend on the response of our immune system, from the innate immunity to the adaptive immunity. And so in short, CMV virus is immune modulating virus. So it can shaping our immune system in health and in disease. And so the spectrum of the CMV disease, it is in the range of CMV infection, which usually asymptomatic and only we detected by blood through viral culture or antigen anemia or DNA PCR viral load, or CMV syndrome, which is characterized by flu-like symptoms, viremia, constitutional symptoms, leukopenia, thrombocytopenia. And the last one is the CMV disease, which is referred to the combination of both CMV syndrome and confirmed tissue invasion disease, which can affect any organ like hepatitis, nephritis, colitis, retinitis, pneumonitis. So CMV is a quite common and serious infection after kidney transplantation. And in this table, I will focus on whom at risk of CMV infection or disease if we are not giving them a preventive prophylaxis therapy. So in this table, I adapted from Handbook of Kidney Transplantation to stratify the serostatus of the patient, and it is very important as part of the workup of kidney transplant to identify whom at risk for CMV infection. And we can start with the first group, which is the high risk group when the donor is negative and the donor is positive, giving organ to a negative recipient, and they are at high risk of primary infection, reach up to 88%, followed by disease rate up to 80%, and even pneumonitis up to 30%. The second group is when both the donor and the recipient are positive serology for CMV, and here the risk of reactivation or superinfection is more and can reach up to 70%, followed by disease up to 40%, which is quite significant. And actually our population here in Oman, it fits this risk stratification. We have, I can say 90% of our population fits in this group of donor positive, recipient positive. Followed by the third, which is again, we are having such population of unknown or maybe donor negative to recipient positive, or unknown donor, like in commercial transplant. Here, again, they are at risk of reactivation whenever they receive anti-rejection or intensification of their immunosuppression, and there is a risk of CMV disease up to 65%. The fourth group, which is the lower risk group, when both donor and recipient are negative, and there is no role for like prophylaxis in this category. So what we have as a prevention strategy for CMV infection so far, we have either chemoprophylaxis for the high risk group candidate, and this will give a prevention rate up to 80%. Usually should be started in the first 100 days to 200 days, depend on your induction immunosuppression type. When there is induction with ATG, there should be prolongation of the chemoprophylaxis therapy up to 200 days as per the American guideline. And the alternative is the preemptive early therapy, when you confirm the viremia immediately after like frequent or CMV PCR surveillance. Both having like the drugs that are using for CMV, we have oral galcyclovir in the dose of 900 milligram per day, and this dose should be adjusted according to the creatinine clearance if a drop of creatine clearance less than 60 ml per minute, and in children, the dose should be adjusted to the body surface area and should not exceed more than 900. Alternative, we have valacyclovir 2 gram per oral for 4 times daily. It is only recommended for prevention in kidney transplant recipient. However, the use of such chemoprophylaxis is limited by the number of the pills and also the neurotoxicity. And you need, of course, to monitor the adverse effect when you start this chemoprophylaxis, in particular, the hematological side effects, including neutropenia, thrombocytopenia, and it should be ideally you do full blood count every 2 weeks. However, in a small study with limited evidence, they show that low dose of valganciclovir of 450 milligram once daily was found to be effective as a standard dose of 900 milligram and effective in prevention of infection without increasing risk of CMV resistant. However, the evidence is limited to small study, as I said, and it is not a common practice in UK. So, in prevention, what have been mentioned now, we have in this table, I would like to show you the pros and cons of this available preemptive versus antiviral prophylaxis in terms of the cost. Like preemptive therapy is increasing the cost of lab screen, and while antiviral prophylaxis increasing the cost by the therapy itself. And regarding the ease of coordination, definitely with antiviral prophylaxis is easier to coordinate. However, you should monitor for the drug toxicity, while in preemptive therapy, there is difficult to coordinate with the lab, with follow-up of the result, the appropriate time for starting the treatment, especially when there is no standardization among centers about which level of CMV virus to start the early therapy. Another pros and cons related to antiviral prophylaxis, usually it is associated with higher risk of toxicity and higher risk or incidence of late onset CMV in high risk group, donor positive, renal recipient negative. However, it is better in protection against other herpes viral infection and protection against indirect effects of other the CMV virus. And there is another cons against the preemptive therapy. There is a risk of escape infection, and especially when there is rapid replication of the virus. So we have also, even in the prevention of CMV, we have a lot of limitations and need to be improved. So regarding the diagnosis of CMV infection, so we have in addition to the physical history and physical examination, we have different methods to help in the diagnosis of CMV infection. I will start with CMV serology, including IgM and IgG. It should be not considered as part of the CMV diagnosis because it is limited by the false negative, false positive result, especially with IgM serology. When you get IgM serology positive, you have always addressed the recent blood or blood product transfusion or recent use of IV immunoglobulin that give you false positive of IgM serology. And this CMV serology is just restricted for the stratification of the whom at risk for infection, primary infection or reactivation. So it should be part of the workup of transplant for the donor and recipients to identify the high risk group and to decide your prevention strategy. The next for the method to use for the diagnosis of CMV, including viral culture, this is also of limited utility because it needs longer incubation period up to 21 days. So it means this will help, will delay the diagnosis and also the initiation of a treatment and so lose its sensitivity. and no more use actually. CMV antigenemia by rapid antigen assay, we can do it in blood and CSF. Also, it is no more like recommended because a lot of like false negative, false positive result, especially we depend on the expression of this antigen level on the present in the leukocyte, and we know that can be false negative result or lose the sensitivity when we have leukopenia. So the quantitative nucleic acid amplification test, this is the new like terminology. Previously we call CMV PCR viral load in the blood or in the whole blood or in the plasma. This is the gold standard for the diagnosis and also monitoring the response to treatment. However, negative CMV viral load in the blood does not completely rule out the presence of organ CMV disease invasion, particularly in CMV colitis. And CMV colitis, retinitis, and pneumonitis. Immunohistochemical staining for viral inclusion body, the characteristic of our eye appearance. This is like, this is the 100% specific for the diagnosis of tissue invasive CMV, but need expert pathologists, and also it is rather invasive procedure because we need tissue biopsy. However, there is still possibility of false positive negative result in case of focal viral invasion. So we finish with the diagnosis and the prevention, and now I will move to the definition of late CMV infection. You know that the CMV virus is one of the viruses that give long lifelong infection and can pass to the latency. So with latent CMV virus is more in high risk recipient immediately after stopping the antiviral prophylaxis, and it is reported to be in the range of 15 to 38%, or through the acute rejection treatment with high frequency up to 65%, or when we have dynamic variation in our CMV specific cell-mediated immunity. So what are the strategies to prevent late CMV infection? We need regular clinical assessment and frequent monitoring by CMV PCR after stopping the prophylaxis therapy, especially in the first 3 to 6 months after stopping the prophylaxis. We need to keep the patient on close monitoring with CMV PCR because this is the high frequency of getting reactivation of latent infection. Also, we can consider prolonged antiviral prophylaxis. This is in particular used now and recommended to prevent CMV latent infection in post-lung transplant because they have higher incidence of CMV, and they recommend extended of the CMV prophylaxis between 6 to 12 months. And also you have to monitor the percentage of lymphopenia. Those who have persistent lymphopenia consider high risk for reactivation of latent CMV. And also there is a new approach for the screening is the monitoring the level of CMV specific cell-mediated immunity, which reflect the functional immune assay, like they doing like interferon gamma, like the TB, screening for latent TB by AGRA test, or they quantify the functional adaptive cells like CD8 and CD4 level. So we will move now to the traditional treatments available for CMV infection after transplantation. And we have the first line, which is the ganciclovir giving IV, or valganciclovir giving oral. And remember, valganciclovir can be used for prevention and for treatment. The second line of treatment of CMV infection, including foscarnet and cidofovir. So again, this table, I will summarize the benefit and risk of these like two lines available for the traditional treatment for CMV infection. The first line, ganciclovir, valganciclovir, and the second line, cidofovir, foscarnet, all of them share same mechanism of action by inhibition of the viral polymerase, DNA polymerase inhibition in this site, UL54. And the first line have a main side effect, including hematological toxicity with myelosuppression that limit the use of and affect the efficacy of these drugs. And the cidovivir foscarnet with the second line, even more nephrotoxic, associated with acute kidney injury and nephrotoxicity, in addition to the neurotoxicity. So we have challenges and we have unmet medical needs in the management of CMV disease, and this can be summarized by drug toxicity, resistance, cross-resistance with the second-line treatment. We have a risk of a breakthrough CMV infection, especially with subtherapeutic dose of the chemoprophylaxis or treatment. And we are also having emerging risk of refractory or resistant CMV infection. So what we mean by CMV resistant? By definition, CMV resistance or refractory CMV, it could be categorized to the probable refractory CMV infection when we have persistent viremia after more than 2 weeks of appropriate use of antiviral therapy, or refractory CMV infection when the CMV viremia that increase even more than 1 log despite in the blood or serum despite appropriate treatment with antiviral therapy for more than 2 weeks. And we have antiviral drug resistance, like in particular ganciclovir resistance is an emerging problem now, and this is mainly due to the viral genetic mutation and this level of UL97, UL54, and others. And this is like even there is emerging resistance to the first line and even cross resistance, especially when there is combination of viral more than like mutation in more than 1 gene. So there will be increased risk or even for resistant to the second line therapy of CMV. So whom at risk of CMV resistance or refractory CMV? Those with prolonged antiviral treatment, those with the previous antiviral exposure or recurrent CMV infection, those who cannot tolerate gut absorption or drug conversion, the type of transplant, as I told earlier, like recipient of lung transplant or intestines are at higher risk, or even stem cell transplant, they're at high risk of CMV resistance or refractory CMV, and also the intensity of the immunosuppression therapy, including induction or the net like maintenance immunosuppression. So with these limitations of the treatment, of the traditional treatment of CMV, we have a new novel treatment for CMV infection, and I will mention 2 medications. Letermovir. Letermovir is accepted mainly for the prevention of acute CMV infection in hematological stem cell transplant. It's mainly act on the viral terminase complex or protein kinase. So it is not through the DNA polymerase inhibition, which is good that it is less risk of genetic mutation and less risk of resistance, have a fewer side effects compared with the traditional treatment, and it is cost effective compared to the early therapy. However, there is a large cohort study shows that the dual therapy of letermovir plus valganciclovir might be a practical and hopeful approach for treating ganciclovir resistant cases, and it is still like not like it is still in a few studies. Like one of them is large cohort study just recently published. There is another novel therapy for CMV infection. We call it marbivivir. The structure of marbivivir belongs to the benzimidazole nucleoside, and it's acted through the inhibition of the UL97 polymerase viral inhibition. Maribavir is FDA approved for the resistant CMV infection in children above the age of 12 years and in adults for both transplant, solid organ transplant, and also stem cell transplant, have a fewer side effects. It can be given orally. However, it is very high cost, but it is recommended for resistant CMV infection. However, there is resistant cases were also recently reported in phase 2 trial due to the, again, genetic mutation at the UL97. And I give you this link to read more about this Maribavir. It is updated in the UK guideline for the treatment of CMV, just like published in January 2023. So as you see in this picture, Maribavir is act on inhibiting of the viral replication synthesis on this level of viral replication. And other new antiviral therapy, we have brincidovir, vilociclovir, and valinocotamide. These are essentially preventing the viral DNA replication and genomic expression. However, it is still in the preclinical research trials, but it is good to know about them. So I just want to remind you about 4 principles about the CMV prophylaxis and treatment. Principle number 1 is the serological status of the donor and the recipient will determine whom at risk of the disease. The intensity of the immunosuppression determines the risk of the disease. Valganciclovir is licensed for prophylaxis, but also it's used for the treatment of the disease. And high-risk patients remain at risk of CMV viremia and latent CMV immediately after stopping the prophylaxis, so high risk of latent CMV. So CMV, I will just now review what we are doing in our institute and are we need to change our practice. So our CMV prophylaxis protocol in SQUH, it is again, we identify whom at risk. So the high risk group, they should receive as a preventive strategy, they should receive oral valganciclovir 900 milligram per day for 3 months, with close monitoring for CMV reactivation by the CMV PCR, and should be introduced after transplantation and should be continued till the end of the first year. All CMV positive kidney transplant recipients, which is our population, need an antithymoglobulin as induction. And in fact, in SQ, we are doing only induction with ATG. We don't have access to bisleximab. So they receive intravenous ganciclovir in the range between 1.25 to 5 milligram per kg, adjusted according to the renal function for the duration of the antithymocyte antibody therapy, then followed by oral valganciclovir 900 milligram once daily for 3 months. And I put it in red because I need to discuss this later on. The slide is not moving. Okay, sorry. So as we told, this prophylaxis therapy should be adjusted to the creatinine clearance in adult and to the surface body area for the pediatric age group. And our protocol for the treatment of the CMV is not different from the guidelines. And we choose valganciclovir oral 900 milligram BID for 3 weeks, then 900 milligram for 4 weeks, until 2 negative blood sample for CMV PCR. Alternative, we can use ganciclovir IV 5 milligram per kg BID dose for the first 5 to 7 days, then followed by oral valganciclovir BID for another 28 days or until 2 negative CMV PCR samples with weekly CMV PCR in the first 4 weeks, then every 2 weeks. Alternative to that, can use ganciclovir IV dose continuous for 3 weeks. Then we shift to valganciclovir 900 milligram oral for another 28 days. or until 2 negative CMV PCR samples negative. And of course, we will aim to reduction of the anti-metabolite by 50%, whatever you have, like MMF, myofortic, azathioprine, and we will keep the same dose of tacrolimus. So what I'm suggesting for the current SQUH protocol, I suggest that the duration of valganciclovir prophylaxis to be 200 days in high-risk living donor kidney, as the guidelines is mentioned. And especially we are receiving like ATG as induction. I would like to add basliximaz as formulary induction immunosuppression for the low and intermediate immunological risk, and to limit the use of ATG only for the high immunological risk. Also, it is very important to extend the chemoprophylaxis after acute rejection treatment for 3 months with frequent monitoring of CMV PCR after stopping chemoprophylaxis every sorry. Yes.
Continue, please, Dr. Saja.
Okay, sorry. So the modern treatment lines for management of CMV infection in transplant recipient, we already discussed the traditional treatment and their limitation in terms of side effect, toxicity, resistance, and even the novel drugs, letermovir and mibravir. But there is a new shift or lines of managing CMV, including the cell immune therapy and the gene directed therapy. This is limited to case series and case report, and also it is in the level of research part, because we need more prospective randomized control trial to address the safety of these new therapies. So I will touch the adaptive cell therapy. Usually, adaptive cell therapy refers to the activation of the CMV-specific T-cell immune response by either like increase the expansion of functional T-cells or direct selection of the functional T-cells, or using genetically engineering high-affinity T-cells. And this adaptive cell therapy, it's a new shift in the controlling of resistant or refractory CMV infection, but it is still in the clinical research. So there is another indication of this adaptive cell therapy, including post-transplant lymphoproliferative disorder with refractory to treatment, or high-grade lymphoma, non-Hodgkin lymphoma, graft versus host disease, EBV virus, BK virus infection or disease. Also, there is a future suggestion of CMV prevention, including the pre-transplant period. We are focused on the hope we get the vaccine for CMV for high-risk group like the recipient, and also we do baseline immune assay. In addition, we target the positive donor by intervention with reduction of the CMV viremia and reduce the tissue burden before donation by giving antiviral, targeting the antivirals, or targeting the latent CMV reservoir. While in post-transplantation, the new suggestion is to focus on the screening rather than like chemoprophylaxis. So including baseline weekly CMV PCR and immune assay, and also your choice of the the induction immunosuppression should be targeting the monoclonal antibody instead of the polyclonal like ATG. And once the patient have viremia, then start the early therapy. If there is no viremia, then to consider stop surveillance when patient out of risk. So after this comprehensive review, I will discuss this case with you. This is a real case, have been treated a long time in 2017. So Mr. AM is a 54-year-old Omani male diabetic, hypertensive, and assumes that his primary disease is related to diabetic nephropathy. He was dialyzed for a few months through Permcath. Then he underwent commercial kidney transplant from unrelated living donors in China in April 2014. There is a history of delayed graft function requiring hemodialysis for 2 weeks. We don't have any information of his immunological risk or the type of induction immunosuppression or his viral serostatus. He's on triple maintenance immunosuppression, including cyclosporine, MMF, and prednisolone. So he came directly from the airport, as usual, all the commercial transplant. He had a fever with no clear focus. However, he was in the hospital before coming to us like more than 1 month, and he had Foley's catheter with vascular access in situ. We did Doppler ultrasound. There is normal size graft and good perfusion. There is no collection. And upon admission, we did pan-septic workup, including urine culture, blood culture, central, peripheral, viral screen, including CMV, EBV, BK, and chronic viral screen. And we started him on empirical antibiotic with hydration and continued on the same immunosuppression, waiting the cyclosporine level. And of course, we assessed him for the need of hemodialysis. In further workup, cyclosporine level was acceptable, and he had gram-negative bacteremia, ESBL E. coli sensitive to Humira, so he received a full course. And also he got staph epidermidis coagulase negative, possibly it is line-related, so we treated with the vancomycin and we removed this line. However, his CMV PCR was positive, but it is less than 2,000 unit per liter, and we start him on renal adjusted dose of valganciclovir 450 milligram. But he had persistent anemia with lymphopenia, leukopenia, but normal platelet count, and he continued to have acute graft dysfunction. So I can share with you his full blood count, and we can see clearly he had persistent anemia, persistent lymphopenia, leukopenia, but there is normal platelet count. And upon, as I told you, he had a gram-negative bacteremia, so with high inflammatory markers. However, it is improved with the treatment. And the first CMV DNA detected in the plasma is less than 2,000. But despite the treatment, the hydration, the antibiotic, the improvement also of inflammatory markers, he continued to have worsening graft function and this persistent lymphopenia and leukopenia. So what's next? So we did a graft biopsy. So, and you can see in this graft biopsy by light microscopy, there is dense area of interstitial inflammation with the tubulitis, and there is lymphocyte predominant infiltrate, which indicate tubulitis. And also, in addition to the tubulitis, we have also this tubule with vacuolization. It is indicate acute tubular injury. And in this hematoxylin and eosine stain, you can see there is a nuclear inclusion bodies invading the epithelial cells in one tubule. And when we did immune histochemical stainings, it showed positive, strong positive staining for CMV viral inclusion body. So even in the glomeruli, we can see this cellular inclusion, nuclear inclusion body invading the endothelial cells inside the glomerulus. And it is again positive staining for CMV inclusion bodies inside the glomerulus. And even in the peritubular capillary endothelial cells, nuclear inclusion bodies. And when we did the immunohistochemical staining, it showed the positive staining for CMV. So we can see that his CMV viral load, it was in the beginning less than 2,000. Within 3 days, it jumped to more than 700,000. Means CMV PCR log increased by more than 2.6 log. This is another indication of when there is rapid or fast replication indicate the risk of CMV disease. So we are dealing with acute cellular rejection and CMV disease, in particular CMV nephritis. So how will you treat this patient? It is challenging case. So need multidisciplinary approach by including the transplant nephrologist, virologist, and ID team. And we decided, after discussion, to go for combined therapy, targeting both acute cellular rejection and CMV nephritis. And we pulse him with pulse methylprednisolone for 3 days. We reduce his MMF by 50%, and this is consultant decision. And we modify his immunosuppression to tacrolimus-based because there is acute cellular rejection with cyclosporine, and we're targeting the level between 6 to 8. However, his level not reach more than 6. And we start him on ganciclovir IV renal adjusted dose for 3 weeks with weekly CMV monitoring. In addition to other supportive care, and we also involve the patient in the discussion with the risk of the reduction of the immunosuppression and the antiviral side effects with the possible even getting CMV resistance. However, likely this patient upon follow-up, he is improved and the best creatine is reached to 122 and off dialysis with estimated GFR more than 50. And upon follow-up of his CMV PCR is the lowest detected is around 1,500. Then we shift him to his regional hospital to complete the course of this valganciclovir treatment. So to conclude and take home message, CMV infection is very common after solid organ transplant, and it is associated with high risk of morbidity, mortality, graft loss. Prevention of CMV infection has been challenged with the post-prophylaxis relapse of the disease on drug toxicity, high cost. The CMV quantitative nucleic acid test is the ideal for the diagnosis and monitoring treatment response and even deciding about early therapy. The immune histochemical staining for viral inclusion body remain the gold standard with 100% accuracy in the diagnosis of CMV tissue invasion disease. And valganciclovir is the standard of care for prevention and treatment of CMV infection. There is emerging problem with the breakthrough CMV reactivation and the development of CMV resistance infection after transplantation. However, we have promising novel therapies still in the clinical research, including the adaptive immune cell therapy and gene-directed therapy, and the CMV vaccination, unfortunately, not yet available. So this is all. Hopefully you enjoy the presentation, and thank you.
Thank you very much, Dr. Saja, for this valuable lecture. Actually, glad to hear all this knowledge summarized in one lecture. We want to welcome to Dr. Olatezi, head of the team of the ZMKC in Nigeria. Also, we welcome to our dear Professor Dr. Magdi Sharqawi from Egypt, and we are appreciating all the support from Egypt and in near future from Nigeria. Welcome to Dr. Amiru Nagi, head of the Onco-Nephrology Center in SQUH. Please, all audience, if you have any further questions or concern about CMV infection post-transplantation, please don't hesitate to ask.